Let's get right into it. If you're aiming for that Delta virus, Hepatitis D virus, 10 marks exam ready status, you're in the perfect place. We're doing a rapid fire, high yield explainer today to make absolutely sure you secure every single point on this topic. We've taken all that dense medical literature and just boiled it down to the absolute essentials. So let's get to work. Okay, here is our game plan. We'll hit the virology of hepatitis D, spread and transmission, the massive difference between co-infection and superinfection, serology and diagnosis, and wrap up with treatment and prevention. All right, part 1, virology of hepatitis D, the parasite of a parasite. Okay, major board alert right out of the gate. HDV is what we call a defective virus. It is basically the ultimate molecular hitchhiker. You see, it has absolutely no independent existence. None. It relies entirely on the hepatitis B virus surface antigen, that's HBsAg, just to replicate and encapsulate. Without hepatitis B, hepatitis D is, well, practically harmless. And that singular dependency, that's the foundational key to literally everything else we're going to discuss today. This pathogen is just astonishingly tiny. Seriously, it has the smallest genome of any known human virus. We're talking just 1,700 nucleotides. And because it's so small, it has to be a master hijacker. It's the only member of the genus Delta virus, and it's a single-stranded circular RNA of negative polarity. It expresses the hepatitis D antigen in 2 distinct forms, small for replication, large for assembly. It literally steals your own host RNA polymerase II to replicate itself. Plus, both HBV and HDV sneak into our liver cells through the exact same door, the NTCP receptor. Moving on to Section 2, Spread and Transmission, Identifying the At-Risk Patient. 12 million. The current global prevalence of HDV infection is sitting at an estimated 12 million people. I really want that number to just anchor in your mind because it shows just how severe and widespread this disease footprint actually is. It's a massive global health burden. So how exactly does it spread? Well, since it relies on hepatitis B, it shares the exact same transmission routes. We're talking parenteral, sexual, and perinatal. Now, when you're tackling a clinical vignette, patient demographics are almost always your first big clue. Are they from a highly endemic region, like the Mediterranean Basin, Africa, South America, or the Middle East? Or if they're from a non-endemic region, is there a history of injection drug use or hemophilia? And keep in mind, modern migration patterns are actively blurring the lines between these areas right now. All right, Section 3, co-infection versus superinfection, the clinical core. If you really want to know where the major exam marks are won, it is right here. Let's use some active recall for a second. How does the exact timing of an HDV infection actually change a patient's prognosis? Like, does it matter if someone contracts B and D at the exact same time versus getting D when they already have chronic B? The short answer is yes, it matters a lot. The clinical pathways here are drastically different. Let's look at co-infection first. This is when the patient gets hit with acute HBV and HDV simultaneously. Now, this will trigger a severe acute hepatitis, sure, but it's generally self-limited because the immune system typically clears the HBV. And remember our rule, if B is gone, D is gone. But superinfection, that is a completely different beast. This happens when HDV superimposes on a patient who already has an existing chronic HBV infection. It causes this severe clinical exacerbation, almost invariable chronicity, and a really rapid aggressive progression to severe liver disease. To really put the severity of that chronic HDV superinfection into perspective, longitudinal studies show an annual rate of cirrhosis in these patients of 4%. 4% every single year. That statistic just perfectly highlights why a superinfection transforms a relatively mild or inactive hepatitis B case into a rapidly progressive, life-threatening situation. Jumping into Section 4, Serology and Diagnosis, the evidence. Okay, for your exams, distinguishing a co-infection from a superinfection in a lab report is absolutely critical. If a patient is positive for both the hepatitis B surface antigen and anti-HDV, you need to look directly at the hepatitis B core antibody. The class of this specific antibody is your golden differentiator. In a simultaneous co-infection, you're looking at an acute phase, so you are going to see IgM. But if it's a superinfection, that acute phase is long gone, right? So you'll see IgG. A quick memory hook I like to use. IgM stands for a momentary co-infection. IgG means the HBV has been there a good long while. Now, while that serology is heavily tested, you should know that relying purely on antibodies can be a bit tricky early on. It can actually take up to 30 or 40 days for anti-HDV antibodies to even become detectable. So, to confirm active viral replication during that early window, you have to do direct testing for HDV RNA or the HDV antigen right in the serum or liver.
And our final section, number 5, treatment and prevention, modern management.
So historically, pegylated interferon was our go-to standard, but honestly, it demands a year of treatment and has notoriously high relapse rates. But check out these emerging therapies, because this is where it gets cool. Remember that NTCP receptor we mentioned earlier? Bulevirtide is a lipopeptide that acts basically like a cellular bouncer. It physically blocks that exact entry door. And then there's lonafarnib. It inhibits the farnesylation or the lipid anchoring of the large antigen. So it essentially strips the virus of its ability to assemble itself. Lastly, for end-stage cirrhosis, liver transplantation is a viable option. And interestingly, the outcomes are actually superior to transplants done for chronic HBV alone. I want to wrap up this explainer with one final provocative question for you. What is the single, absolutely foolproof way to stop the hepatitis D virus? You just prevent hepatitis B. Because HDV is entirely 100% dependent on that HBsAg envelope to survive, vaccinating someone against hepatitis B provides total bulletproof immunity against hepatitis D. Literally, no envelope, no Delta virus. Keep that virological dependency front and center, review your serology rules, and you are officially Delta virus hepatitis D virus 10 marks exam ready. Thanks for studying this incredible viral hijacker with me, and I'll catch you in the next explainer.